Good morning and welcome, and thank you for coming. I'm Christopher Spera, Division Vice President of the Health and Environment Group at Abt Associates. Thank you for coming, and thank you for joining our 8th Bold Thinkers event. Our topic today is one of the most urgent issues we face. What will it take to solve the opioid crisis? And if you are on webcast or Twitter, we invite you to join the conversation using the hashtag #OpioidResponse. Not a day goes by without a headline on the challenges opioids presents to families and communities across the country. From urban centers to rural America, the epidemic has spared few. At Abt, we work to improve the mental health, physical health, and well-being of people worldwide. Our broad portfolio in behavioral health includes building the evidence to understand the epidemic. What we've learned along the way, and what many of the distinguished speakers here today will attest, is the only way to improve the health and well-being is to take a hard look at the systems that facilitate or impede access to care and treatment for people with opioid use disorders. Whether it is a patient who is suffering from a back injury or a person who feels disconnected from her friends, family, and community, pain is a real issue. Prescribed opioids, for as much newsprint that has been devoted to them, have saved thousands of lives and do improve the quality of life for many who suffer from chronic pain. When we think about the way forward, we know that healthcare providers, agencies, and communities understand opioids play a critical role in treating patients with chronic pain. But of course, these medications must be used in ways to prevent misuse. We strive to reiterate in all that we do at Abt that substance and opioid use disorders are not moral failings. They're not. They are complex medical conditions that have clear evidence of brain-based biology. As we do our work, we remind ourselves and others that each person who struggles with substance use disorder is a person, first and foremost. Let's change the way we talk about substance use and see the people for who they are. Sons and daughters, mothers and fathers, brothers and sisters, friends and coworkers, people you know, maybe you. And no matter what the headlines of the moment are, let's take a look at the long history here. While the epidemic has received a lot of attention lately, it is not new. We can track spikes in prescription drugs and heroin use back to the 1980s, predominantly in under-resourced communities of color. While everyone is affected by the opioid crisis is grateful for the influx of new resources, it's important to recognize that the next epidemic is just around the corner. And we must remember that alcohol use actually remains the third leading cause of death in the U.S., killing far more many people than opioids or other drugs besides tobacco. Looking forward, we need to think proactively about how to use the lessons we've learned in behavioral health to deal with opioid issues, alcohol and tobacco, and to build an infrastructure to prevent existing and future substance use epidemics. This includes examining the intersections, including the intersection between behavioral health and criminal justice. And there were signs of this opioid epidemic as early in 2007 that we saw in our work at Abt Associates. For over 10 years, Abt ran the Arrestee Drug Abuse and Monitoring Survey called ADAM. First, we did this on behalf of the National Institute of Justice, and then later for the Office of National Drug Control Policy. If you're not familiar with this survey, the technique includes interviewing folks after they were arrested within 48 hours in as many as 35 urban jails across the country. And it sounded an alarm back then about the emerging opioid epidemic that we are now seeing. For each year until the program ended in 2014, a growing number of 18 to 24-year-old arrestees tested positive for opioids in cities not traditionally facing the opioid problem. Cities like Charlotte, Indianapolis, and Denver. While we were used to seeing the opioid use issue, primarily aging adults using heroin in places like New York and Chicago, this was not true in other cities and not among younger arrestees. So we saw the early warning signs back in 2007. Many of the people with substance use disorders who wind up in the justice system suffer from trauma histories and have lacked access to equitable education and employment opportunities. We know many people who are incarcerated need treatment and recovery supports, particularly upon re-entry back into the communities. We're finding ways local programs and agencies can improve re-entry services to address critical determinants for well-being, such as safe, supportive housing that can prevent relapse and overdose. And working with federal, state, and local partners, we're finding effective evidence-based ways to address needs to prevent someone entering from the criminal justice system at all, including helping them access needed treatment for service. Beyond criminal justice, there are multiple other systems at play here. For instance, in the child welfare system, we're seeing a new generation of children being raised by grandparents based on the epidemic. The impact on the crisis of children, families, and schools continues to grow, and we are proud to support at Abt child welfare grantees developing strategies to create proactive efforts to help families, and we know more needs to be done. Likewise, employers in states hit hard by the epidemic are having difficulty finding workers and helping to reintegrate people in recovery back into the workforce. And of course, as some of our esteemed panelists you'll hear from today, the epidemic is straining the healthcare system. It really is, including primary care docs, specialists, clinics, and hospitals. At Abt, we've had the privilege of working with CDC on developing prescribing guidelines for treatment providers, along with implementing guidelines. We know, though, this is just the beginning. As we facilitate and discuss with our panelists today, I'd like to put some questions out there for you all to think about and for our panelists to respond to. These are important policy questions that must continue to be addressed. First, how can the justice and public health systems work together to keep people with opioid use disorders out of prisons and jails? Secondly, how do we resolve the tension between helping people manage chronic pain and misusing opioids? And then lastly, but not least, how do we ensure limited resources are used on effective evidence-based interventions? Our discussion today will no doubt advance the conversation in solving this critical problem, and most importantly, saving lives. This short video that we're going to show, Project SAFE, a nonprofit organization working to stop addiction fatality epidemic, shows the true cost of this crisis. We're now going to show the video.
What's your name?
Jocelyn.
Very powerful video. Reminds us all why we're here today. I'm now going to call up Sarah Jalbert, who is a principal associate at Abt, to facilitate our first panel on the intersection of criminal justice and public health. Sarah?
Thanks, Chris, and I'd like to ask our panelists, Commander Burke and Dr. Gupta, to come on up, and we'll start the discussion. Thanks so much, everyone, for being here. I'm really excited for this conversation and our opportunity in this first panel to start answering some of the questions that Chris posed. Before we get started on the discussion, I'd like to give each of our panelists a couple of minutes to introduce themselves and describe their perspective on the opioid crisis and their experience with it. So, Commander Burke, you want to go first?
Thanks. Thanks, Sarah. My experience actually began, and just is going to tell you how old I am, back in the late 60s. In the late 60s in America, there was a huge heroin problem, pretty much inside the African-American community. The heroin was not near as pure as it is today. Everybody injected it, and it went on from there. So that's when I started my 49 years of law enforcement. I was 32 years with the Cincinnati Police Department, so I had a city perspective. Then I spent 16 years in charge of a HIDA initiative in Warren County, Ohio, which is just north of Cincinnati, for 16 years. And then I spent the last year probably with a very rural county, Brown County, which is just east of Cincinnati, which has one of the highest per capita overdose rates in not only in the state, but also in the country. So I've kind of had experience with three different kinds of law enforcement, and some things have worked and some things haven't, and I'm sure we're going to talk about that today. I'm also very much a pain patient advocate. That may seem strange to you to have a cop to be a pain patient advocate, but I am, and I see that group as I think Chris mentioned briefly, as a group that is part of the collaborative damage of the opioid problem. I also was involved in getting the issue passed in Ohio to allow law enforcement to use nasal naloxone, and it is provided. And if it wasn't for nasal naloxone, our funeral homes would be filled in Ohio. And it has been a great thing from that standpoint, giving people a second or third or fourth chance. And there's been some, Dr. Gupta and I talked about it earlier, but there's been some pushback. It's not mandatory, so some law enforcement agencies haven't adopted it, but more and more, I think, every day are. So I'm past president of a group called National Association of Drug Diversion Investigators. I formed and co-founder of the International Health Facility Diversion Association, which is a group that we look at, and that certainly involves addiction, drug diversion inside hospitals and nursing homes. And that is almost exclusively addiction there. So I've kind of run the gamut, and that's where I'm at.
Thanks so much.
Thanks.
And Dr. Gupta?
Well, again, thank you for everyone for being here, and thanks certainly to the Abt folks for organizing this very important topic. You know, as a practicing clinician, internist for about 25 years or so, I could tell you that this is certainly the biggest challenge that folks like me have faced in their lifetime. And part of the reason for the challenge, I think, is that the complexity of the epidemic. The nature is such that it's very difficult for us to even understand the full strength. I mean, when we look at states like West Virginia, Ohio, Kentucky, Pennsylvania, what's happening is very much this crisis is unweaving the very fabric of our society. And part of that reason is obviously prescription drugs, but part of its socioeconomic conditions, part of it's the culture, part of it's the, lots of other factors that go into this that has caused this. So the response and the approach to understanding cannot be one-dimensional. And I think that's the part that I have personally found to be most fascinating in all this. Whether it's the babies that are being born dependent on opioids, with West Virginia's rate being 5%. We're talking 5 out of 100 babies. not 5 out of 100,000. The US rate is about 1%. We've made some estimation that every baby that's born in West Virginia, it costs about $1 million just for the immediate cost of that baby, and not even understanding the long-term impacts. So if you think about the liability that we're incurring as a nation, in addition to pretty much losing a generation in the coming times, and this is certainly a transgenerational issue as well. Understanding that, and then we talk about not only the working population, but also individuals that we'll focus on today, about incarcerated individuals that are so critical to our workforce, as well as a sort of almost unidentified senior population that has now sort of gone underground in some ways, because they're also using a lot more IV drugs when the physicians would tell them that we cannot write for you any longer prescriptions. So even the pendulum shift is concerning, as the commander mentioned, for prescriptions, because I think that's giving us issues with other things that are happening. But what we're seeing at the community level is the basic challenge on a day-to-day for individuals to survive, but also then issues of stigma, because one of the things we deal with every day is the sort of distinguishing factor between whether it's a choice or it's a disease. And I can tell you right now, as more and more we talk about, the country is pretty much split on that, and it's very difficult. We go back to understand that to the AIDS epidemic, and it is just so much more difficult now to get people to understand and educate that this is a chronic relapsing brain condition. We have to give individuals a chance to survive, and evidence-based treatments have to be offered.
Thanks. So I think one of the things that we hope to talk about today, having representatives from public health and the justice system here, is the current state of collaborations between the systems, and then move to the future state where we should be. So I'd ask both of you, where do you think we are in terms of the justice system and public health systems collaborating and working together effectively to address this?
I don't think near as close as we should be. I have attended and lectured at many CE programs, pain for docs. In fact, if I was a doc, I'd have CEs for the rest of my life. But one of the things we discussed is that I haven't really seen, and Sarah mentioned maybe she did recently, is that I would like to see law enforcement and prescribers in trainings together. We tend to go to our own thing, and so that when I'm back to the pain patient advocate thing, I've seen this firsthand at my home, and I understand it, but most law enforcement officers don't. And I think it would be a good mix to have them together and get each person's perspective so they can understand it better. I understood it better when my mother-in-law moved in with chronic pain. I got to find out about it more than I wanted to. And most people, fortunately, don't get that, if it's called that an opportunity. So I don't see it as really good. I know that there's law enforcement that think that all doctors are, drug peddlers. I mean, that exists. And so I think sometimes when we meet together and go to trainings together, we begin to realize that we all kind of have a common goal. And we just need to talk about it and be together more, if that makes sense.
Mm-hmm. Absolutely.
Yeah, I think collaboration, as I mentioned, the dimensions of this epidemic, I think it's going to be very critical for us to be able to collaborate. We ought to be thinking about every aspect that we have within systems, whether it's grant funding, whether it's approaches to continuing education, whatever the facet of our position is. We've got to figure out, we've got to keep in mind criminal justice system in mind. And so do the policies, so do the grant funders. We've got to figure out how to make sure that in some communities and in some states, there will be a natural collaboration. In others, there might be initially a forced collaboration because the grant funding requires there to be, or other methods. But there's got to be a deliberative process to be able to collaborate. Otherwise, I don't think we're going to get there. I'll give you an example in West Virginia. One of the first discussions I had, and the language is different. I mean, I think it's very important to understand the public health typical and criminal justice language is very different. One of the first discussions I had with the cabinet secretary in this area in West Virginia was, he's mentioned that 33 correction officers equals $1 million spent in West Virginia. 37 inmates equals $1 million spent in West Virginia. Well, I'll take that. I'll take that if the incentive is that we've got to not incarcerate individuals because we cannot afford it. We've got to figure out how to get these individuals back into the workforce, reentry, enhanced provision of medication-assisted treatment. And the reasons for that is perhaps financial and economics, great. And public health has to sort of open their mind to those kinds of figures in order to get there. Same way with, as the commander mentioned, criminal justice and our law enforcement folks, lots of our colleagues see this challenge. We recently have had a really good collaboration with folks from DEA. One of the things that has been happening in your communities and others is that every time there's what we call the pill mill bust, we know that there's data to support that there's rise in ER visits, and people obviously want to transition to street drugs. That's not acceptable. We had not thought about, at least law enforcement colleagues had not thought about the collateral consequences of those actions. And now is an opportunity. So what we did in West Virginia is we developed a protocol. When now there is going to be a drug bust, we collaborate and work together with law enforcement to actually help those patients from that clinic reach out to other providers within the area. And that kind of work has to happen because I think we can no longer afford to function within our sort of centers of excellence, or silos, as I call them.
So I think a couple of things that I wanted to circle back on in what you just said. And I think they all kind of go back to this question of, can we find a way for these systems to align their goals? And it sounds like this collaboration with DEA may be one way. And what role does funding have in aligning those goals? And how do you think innovation and funding can help to encourage that collaboration?
I did Dr. Gupta say something I really kind of perked up my ears. Great to hear that what the DEA did. I was involved over the course of time, many arrests of physicians, prescribers that were way out of the scope of legitimate medical practice, but never did we give any consideration for those patients. And we would hear about them. They would say, I lost my doctor and all this, but I'm out of the business, but if I was back in, it would certainly be something that we would look at. That's a great idea, because those people scramble, and oftentimes they have hundreds of patients, and some are certainly legitimate pain patients too. So it's taking care of those that's a neat idea. I like that. That's great. I think I look at this problem, first of all, if anybody, and I don't know if you've ever had this, but I get this occasionally on an email. Somebody will send me an email and say, I've got the solution to the opiate crisis. What's the first thing you do with that? You hit delete, right? Because if somebody had the answer, none of us would be here, first of all. That person would be a multi-gajillionaire. It's much more complex, much more complex than that. I always looked at it as law enforcement, prevention, and rehabilitation. I know those are kind of broad areas, but those three working together. Unfortunately, we haven't really been good at that. Part of the reason is that we compete for grant dollars, don't we? So when law enforcement is trying to say we're the answer and rehab is saying they're the answer, when actually the answer is all of us. And I like a concept of some grants, and I've not seen it, and if I'm wrong, that's great, but or maybe a grant would provide for all of us to work together on one grant and to mandate, not just throw it out there, but mandate that you work together and get a better concept of what each one's doing. I've seen a big change in law enforcement, though. We do work with prevention folks far better than we did when I first came on. And rehabilitation is so important. Probably I hate to say this, my law enforcement people will kill me, but rehabilitation is probably the most underfunded part of this triple thing. And I hate to see us, you guys know, if you've been in this ability, you think, oh, those cops got the money this time, and we need it. We're over here. And each of us think we're the most important, and that's because that's what we work in. But we are much stronger as a unit together. And I think we've got, hopefully, cops have gotten a little smarter that we're willing to work all. It hasn't been, I don't think rehab and prevention's fault. I think you're willing to work with a lot of folks, but I think we're getting better at it. The HIDA is certainly HIDA is the high-intensity drug trafficking area. If you're not familiar with it, it's under ONDCP. And all the years in law enforcement, I became an initiative head in Southwest Ohio, and I found out how valuable it is. You may not know this, but state, local, and federal officers do not always work together really well. It's just the way it is. So that's really stupid, too, when you think about it, but that's kind of been the mindset for a lot of decades until recently. In HIDA, I was in charge, so I had all these resources, federal, state, and local, and so we worked at high-level drug traffickers, where law enforcement should be spending the majority of their money and their time. There's still a ton of bad folks out there that make tons of money off of the sorrow and the sadness of our addicts. And those folks need to be, and they don't take drugs, trust me. They don't take drugs, but they love feeding the addiction. And our area certainly has had an opioid problem, as I know Dr. Gupta's has, but here in the last year, crystal meth has now come back, and cocaine. And so it's kind of a cycle, but it's really all about where can we make the money, the cartels. So my personal opinion in dealing with meth back earlier, I don't know there's any more addictive drug on the planet than methamphetamine. And when you get hooked on it, you're pretty much hooked on it. So I guess what I'm trying to say is I'd like to see grants that supports more unity with all of us, and that we talk together better, not to feud so much over grant dollars. If we're all getting one grant, maybe we can all come together and try and go after that, and then I think we'll function better.
And so related to that, and maybe you can talk about this, Dr. Gupta, so how do we, most grants have performance metrics and have, things that they are intended to do. How do we make sure that grants that are available for law enforcement also have metrics associated with them related to recovery, for example, and supporting, I think in your example, supporting the patients who have lost access, to their prescriber, and working a prevention role or supporting recovery?
Yeah, so I think, one thing we can, again, as without changing laws, we could certainly do is require that there is mutual consent within those grants, because I think both public health and criminal justice can do well in some ways holding each other accountable and being evidence-based, because I can tell you we're still, all of us, as much as I like to, we're all not on the same page. That's just a fact of life, because when we look at more MAT, medication-assisted therapy, and more help to individuals to get them into recovery support and others. There are parts of law enforcement that looks at that as increased diversion of buprenorphine, for example, and that's a concern, like opioids were not before. So I think there's that challenge. Sometimes, I would accept a small increase in diversion of buprenorphine for the massive diversion and street selling of opioids that is happening currently. In 2015, I think we had about 226 million prescriptions or something like that for 300 plus million people in this country. So if you look at that, so I think we're sometimes sort of penny wise, pound foolish in some of these. So we've got to get on the same page to figure out, okay, we've had to have these deliberative policies that will encourage evidence-based treatments. So I think having those, getting everyone on the same page through grant mechanism is critical. The other aspect that we often don't talk about, because that would require congressional action, is this. Right now, there's probably about 19,000 people in prison in West Virginia that have SUD. Typically, the numbers will tell you that there's a very high volume of people with substance use disorder that are incarcerated. And these are all usually working age individuals. So, all the federal programs for healthcare stop at the door once somebody is incarcerated. And it becomes a state and local burden. So the question then becomes is, how do you find those financing mechanisms to help individuals? Because it does cost money when you're talking about, MAT and other aspects. One of the things we did last year is we wanted to stop this very high rate of neonatal abstinence syndrome. So we said, well, we're going to start, figuring out plans. One of the ways was to fund something called long-acting reversible contraceptives. It's a non-political issue for us because the cost of the problem and lost generation. So we said, well, we're going to offer that in prison to women, and then comprehensive family planning as well. Well, we had to use state dollars to fund those projects because we cannot use federal dollars. So it becomes a burden on state and local governments, actually, to be able to manage those people. Whether we're talking about substance use, we're talking about hepatitis B and C, the prevalence of which is rising. We're talking about other sexually transmitted diseases. We're talking about family planning. All these things are a sort of a out branch of substance use crisis. And it's very critical that we figure out how to do this and do it right within the correction system.
So speaking of the correction system, I think that Chris mentioned in his opening remarks as well, the correction system and some of the pain points associated with particularly reentry from the correction system, and particularly jail reentry, and that can be for reentering offenders a danger point for them for overdose in particular. Are there kind of bright spots that you see in terms of interventions designed to prevent those overdoses? What have you seen in your experience? What do you think could work to help solve this?
I don't know that there's a whole lot of bright spots, so hopefully there are. I mean, I'm going to use this pun, we have a captive audience in jail. Are we not? We have them, they're not going anywhere. So they're a captive audience. Why aren't we utilizing extensive programs inside these jails? And some of this is, it's not all of the penitentiaries. Dr. Gupta is right. The local and state are who has to burn, and they don't have the money. Mm-hmm. They're already, the foster care programs, I don't know, I'm sure West Virginia is the same way. It's incredible. A lady in our church is the foster child kind of group, and she's fostered 60-some babies. And these are horrible kids. If you've ever seen somebody who comes out, and Dr. Webster will tell me babies are not addicted to drugs, but when they come out with that issue and they scream constantly, and the moms never see that, or the dads never see that. But anyway, that's a whole other collaborative thing. What worries me is, too, especially in the last, say, 30 to 60 days, but I think it should be going on the whole time, we get people in the county jail, maybe there for 8 or 10 months. That's a pretty typical sentence. And so they left. When they came out of society, they were at one level of, this is the dose they took. And they go back, they've had no really much rehabilitation or intervention at all, and they come back into society, and guess what they do? They go back to drugs, but they don't only go back to drugs, they go back to the level, the injection level, let's say, that they had 8 months ago. So what do you think happens to a person who's now been off drugs relatively for 8 months? They die. I mean, and so nobody's there 30 to 60 days out, especially those last 30 days, concentrating, if nothing else, and I know we're not encouraging drug abuse, but we're trying to explain to them that, this is a fatal deal if you do this. And that's lacking, at least it is in the places that I'm around. So again, captive audience, some of it is, you mentioned the dollars, it's pay me now or pay me later. You pay me this much now or pay a lot more later if we don't get this handled. That's why, we've got to start thinking that our dollars spent in rehabilitation and in prevention, education is golden. And the trouble is, it's hard to I guess, equate that later. How well did we do? And but we're not putting enough effort into that. So the jails and penitentiary, again, it's a captive audience. Let's go after them. Let's use them. Now, my guess is they don't have to sit in on those, but I would imagine that a good portion of them would.
Yeah, I would totally second that. I mean, the ability for us to be able to treat individuals while they are incarcerated. And I don't mean just with one medication, because one of the things is that we've used this drug called naltrexone or Vivitrol, but whereas FDA approved, there are 3 different medications that are available. So we're still not utilizing to the fullest extent that we can what we have available. We need more treatments, definitely. We need more R&D. But we already have medications that are not being fully utilized to the level they should be. And that's another aspect that I think very important for our law enforcement colleagues to embrace is all those options that are. And then complement that within the system with vocational training. People, part of the crisis is loss of hope. And I can tell you that one of the things that happens is when somebody has hope, they want to be released. Nobody wants to be in prison. I mean, people mostly generally want to go back to their family. They want to have something to look forward to. They want to, including the ability to have a job. And so that time is just a unique time. I think we're missing opportunities within that. Part of that's the funding problem. Part of that's the education and partnerships and collaborations. But the other aspect, I'll also talk about reentry a little bit. We actually started something called Vivitrol Project, where people were voluntarily allowed to get the drug before their discharge and reentry into the community. And one of the things we found in evaluation of that program, that the biggest factor that led people to stop that was actually lack of the community support. They did not know where to find a provider. They did not know how to continue, and that wraparound services that need to happen at community level when these folks are released just do not exist in most communities. So I think one of the challenges is we've got to build that system to make sure that when people are leaving, we conducted a social autopsy of all the deaths in 2016 last year. One of the things we found was 56% of the people within 30 days upon reentry died of an overdose. Goes back to the commander's point. We're losing people so many out of, and these are all, again, working age population because of this lack of community support for these individuals.
So I want to bring it, we just have a couple of minutes left, but I want to bring that back to the role of stigma and how communities can and should support re-entering offenders, ex-offenders, but maybe don't. And what's kind of the role, what's the cultural piece here that is preventing communities from really participating fully in people's recovery?
Well, you hit the nail on the head. The word stigma is probably how we combat that. I don't know. I think we combat it maybe, though, partly by people speaking out, maybe more. And I'm saying maybe more law enforcement. The health industry has always understood this, and I think we're a little slow to react sometimes to this, but I think we're finally getting it, that this is a disease and that we need to treat it. I'm a big fan of Vivitrol, and I don't own stock and I don't speak for them. But I saw a judge in Warren County that did a study with 100 of them. He started them before they got released. And after a year, there was 100% abstinence still. Now, I'm not saying it's going to happen that way, but if you take the shot, your opioid addiction or your opioid abuse days are over for that month. And they say, well, it's expensive. And I said, well, how expensive is an addict? When they're out there stealing and all the things that happens with them trying to get their next fix, a few $100s a month is nothing, and we should find ways to fund that better. And I think money has been a blocking point in part of this, which is kind of sad. It's, again, pay me now or pay me a whole lot later. But I think the stigma comes from, and again, maybe I put it more on law enforcement. They expect, the health community's got it, like I say, for some time. Maybe more in the justice system should be speaking up and saying, hey, this rehab is what we need. We got to break this cycle. This is a revolving door, folks. This is what it is. You guys see it. People get addicted. They get arrested on a charge. Maybe they go to jail. They get out. They go back on it. They have very little support. They probably have very little family support, and the stigma doesn't help that either. You know, it's, well, I don't want to help Jimmy. He's an addict. And so maybe Jimmy doesn't get opportunities that others would. It's a tough thing to break, but it's important to try and do that.
I mean, I think the concept of war on drugs, tough on crime, is one that reverberates with most people, except when it's their own family and own community. So I think it's very important to understand that right now, with 72,000 people dying last year, it's a lot of families that are impacted, a lot of torn communities that is happening. So I think it's important to be compassionate and understand that from a messaging standpoint, while also knowing, as the commanders mentioned, that we've got to worry about the pendulum swinging to the other side and people going in the shadows when they cannot find their prescription opioids or other pain medication. And hopefully there's more research coming that will help us develop non-opioid alternatives. But there's a big population of that too. I want to remind us again that is suffering from pain every single day, and does no good for us to villainize that population either.
Thank you. Well, that's a perfect timing because we are out of time. But I want to thank you so much for this conversation, and I think you've raised a lot of really important points for me and also a number of people in the audience. So thank you very much.
Thank you.